All right. Thank you very much, Ms. Catherine. Really appreciate your helping us out this afternoon. Good afternoon, everyone, or good evening, wherever you are. And welcome to our December Impact with Ages presentation. The topic of our presentation today is the impact of home assessment for the community dwelling older adults. Of course, home is where the heart is, and our goal is to keep the older populations in their homes safe and functional. So here are some housekeeping things that we need to keep in mind as we go through today's training. OTs are required to pass a post-test quiz within 1 week of this presentation in order for them to earn the CEU credit. The link for the quiz will be emailed to all of our OTs and OTAs following the course. SLPs are required to submit the ASHA participant form within 1 week as well. The bubble sheet could be downloaded from the handout section and submit to shaila.amic@aegistherapist.com. That is shaila.amic@aegistherapist.com. Please notify the host in the question future if you have other non-registered participants sharing your screen with you. If you have questions, please use the question feature on your control panel, and we will try to get to them at the end of the course. One more thing, there will be poll questions as we go through the presentation. We want everyone to respond to those questions. So here are your speakers for today. Sally Seals, an OTRL, and Krista Godet, another OTR. Brandy White is an SLP, and I am James Kennedy. I'm a physical therapist. All of us are employees of Aegis Therapists, and we have no relevant non-financial relationship to disclose or discuss. So here are some of our objectives for today's presentation. So at the conclusion of the event, we expect the participant to be able to describe the importance of conducting home assessment for the community dwelling older population. They should be able to identify safety hazards and safety concerns to be addressed during home assessment. They should be able to describe the role of OT, PT, and SLP during home assessment. So these are some of the areas we're going to be covering today. The first one, of course, is what is our home assessment? We want to make sure that we know what we're actually talking about. Then, why is it important? Then we're going to be looking at some etiology, data, stats, and prevalence that might impact home assessment. And then we're going to look at some research studies. We're going to look at therapist role. So let's start by asking ourselves, what is our home assessment? Well, as you can see on this slide, it's an assessment of the home environment to make note of any potential hazards in or around the home to improve function and mobility for our older adult population. And the purpose is to create confidence and independence for individuals to remain in their home safely for an increased length of time with extended success. And then to provide the elderly and caregivers with the tools they need for happy, healthy, and safe living in their home environment and during their golden years. So why is this important? Well, according to CDC, 1/3 of community dwelling adults aged 65 and older will fall every year. And in the United States alone, 1 in 4 adults aged 65 and older falls every year. Now, also according to CDC, falls among old adults 65 years and older caused over 38 thousand deaths in 2021. I'm going to repeat that. Falls among old adults, 65 years and older, caused over 38,000 deaths in 2021. That is a big impact. That makes it the leading cause of injury death for that group. Falls are preventable. It's not inevitable. It can be prevented. And it is not a normal part of aging. Conducting a thorough and comprehensive home assessment can increase safety for our older population. That is one of the reasons we are doing this course. And with increasing aging population, increasing healthcare costs, and desire to age in place, making homes safe for older adults is very important. We want to keep them safe at this stage of their lives. Now, as I mentioned earlier on, we have some polling questions. So here is our first polling question. So in 2021, how many deaths were as a result of a fall in the elderly as reported by the CDC in the United States? I'm going to give you guys a minute to respond. All right.
James, I'm sharing those results. I'm not sure if you can see them.
No, I'm not saying them.
Okay. It looks like 16% said 24,000, 18% said 100,000, 64% responded that it's 38,000, and 2% responded that it's 4,500.
Yes, the answer is 38,000 deaths in 2021.
Okay, so now we're just going to discuss some of the etiology, some stats and some data and the prevalence of those falls that can maybe be prevented. Changes in your body that increase risk for falls. We see that the older adults become weaker at times, they have a functional decline, and this requires a home assessment. Modifications and adaptations to their home can reduce the risk of falls. So thinking about things that we do or don't do that can increase our fall risk. Older adults often are inactive. They have more fear of falling, and they can become socially isolated, which all can contribute to falls. They have a decline in overall cognitive function, causing decreased participation in activities, which cause increased memory issues and increased attention deficit. Some risk factors include decline in physical or mental function, unsafe behaviors, even often things such as smoking, living alone, and healthcare management factors such as polypharmacy, lack of medication review. These can cause accidental injuries in the home. We often find that older adults have a decreased desire to participate in daily tasks, even just for pleasure. They have hazards in their home that they don't even realize are hazards. Maybe even improper use of their assistive device in the home. And then, of course, always that medication use. You can go to the next slide.
Yeah, I'm working on the slide.
Okay, sorry about that, guys. In 2019, the emergency department recorded over 3 million visits for older adults with falls. So between 20 and 50% of inpatients can also be malnourished when they arrive. And so that can also contribute to their falls. About 16 out of 100 people were injured, and about 1 out of 1,868 actually died from a preventable injury in the home and community venue, and that's from 2022. Older adult falls often cost a lot of money as well, about $50 billion in medical costs annually. with 3/4 of that paid by Medicare or Medicaid. So it's a significant amount. And so we're at our next polling question, and it is, what is the average annual medical cost due to elderly falls in the United States?
It looks like responses are starting to die down, Brandy, but looks like the most responses are 46% for 50 billion. And then the next popular answer is 23% for 150 million, then 17% for 750 million, and 15% for 5 billion. So I'll close the poll now.
So most of you were, yes, most of you are correct. It is the 50 billion that it costs each year. There we go. So these are just a few things to look for during the home assessment. You want to look for those trip hazards. Are there any loose rugs, cluttered walkways, uneven flooring, wet surfaces, loose electrical cords? Is there any unstable furniture? Does it need to be fixed or even removed? Maybe it needs to be anchored or even replaced. Inadequate lighting is often a problem. They may need additional lighting in stairways, hallways, and bathrooms. We have to consider the presence of the medical equipment. You know, do they have portable oxygen tanks? Is there a long cord? Do they use a walker or a cane, and can they use those effectively? The presence of pets, children, and toys in the home. If there are pets and children, there's often toys lying around that they need to be more aware of. Safety with their ADLs and their independent ADLs. Are they able to manage their medication safely? Safety with remembering important tasks, like turning off the stove, turning off water, locking the door, or even remembering their appointments. And then the ability to make or acquire appropriate consistencies of food. So if they're on an altered diet, you know, if they're not on that basic regular diet, are they able to fix that food, or do they have someone that can fix that food for them? So places to assess during a home safety assessment. We have to look at the entrances, thresholds, stairs and rails. Is it handicap accessible? Are there any loose bricks or trip hazards? When we look at the living area, is there any unsecured furniture? Are there TV cords, throw rugs? Are there TV dinner trays that they have to navigate? When we look at the kitchen, are there any unsecured cabinets? What is the location of those commonly used utensils and appliances? Do they have access to those? The bathroom, the presence of a nightlight. Do they have grab bars, shower chairs? What type of tub do they have? Is there medication present in the cabinet? When we look at the dining room, we have to look at the size and space for assistive devices. And there again, that's a room that we need to look at that lighting. In stairways, we need to look at loose handrails, uneven steps, loose rugs, and often those are darker areas as well, so we need to check that lighting. When we look outdoors, we need to look at the walkway. How far is it to the mailbox? Do they have a garage entrance? How many steps are there? We have to look at the floor and the flooring. Do they have tiles, rugs? Maybe they have uneven floors, or even their thresholds are uneven between their rooms. And then we have to look at the basement. So we need to look at numbers and depths of the steps, because often those steps are deeper and there are more. Is there a rail for stability? And then of course the lighting in that area.
So to make sure that we are adequately assessing all of these areas in the home, there are some checklists that we can use. Now this one has been developed by the National Institute of Health. The National Institute of Health is a very highly accredited entity, so this can be a very beneficial guide to our home assessments so that we provide a thorough assessment or an evaluation for our patients of their environment. So if you look at this, it goes through and asks specific questions to look at throughout the whole home, and then it breaks it down to specific areas. So specifically like floors, I'm looking at stairs, what type of flooring, is there proper lighting, railings, if not, can one be added? And then it also breaks it down into specific rooms. Looking at the bathroom, looking at the kitchen, and asking different specific questions that we would need to focus on in those different areas. This one also includes a section that assesses the outdoor area as well. So looking at locks on doors, what kind of assistive device are they going to need to get in safely? Is there appropriate lighting? Are there uneven surfaces outdoors? Is there a clear path to the house? And also, is there a clear path inside the door once they enter the home? So there's also another checklist that's developed by the CDC, another very highly accredited entity that we can use as a good resource as well. So if you look at this list, it addresses some of the same areas in a very simple format. It breaks it down in all areas of the home to ensure that any safety concerns are addressed. And then there's a third example here as well. This also breaks down all those areas of the home, including those outdoor areas again. These checklists are great guides to use, not only to make sure that we are making sure that all the needs in the homes are addressed, but it's also a great resource to provide to those caregivers as well. So we discussed the patient or the what to look for in the home, but now what about the patient? Are they safe with their assistive device? Is that assistive device appropriate for their environment? We have to consider their medical condition and any comorbidities that they may have. Do they have any visual or hearing deficits that we need to accommodate for? What are their habits and routines throughout the day? What is the availability of caregivers? And what needs are the caregivers to provide? How aware are they of their health conditions and how to manage them within their home environment? What about medication management? And we also want to make sure that the caregivers and patient are aware of any certain safety concerns.
Okay, so I will be talking about some tools that we can use for assessments. So by using some of the tools that I will be talking about, therapists can tailor their interventions, make any modifications to ensure that the homes are safe, functional, and supportive for patient needs. So some of those assessments are the Home FAST, which is the Home Falls and Accidents Screening Tool. This assesses the risks related to mobility, lighting, flooring, and clutter. It also helps identify hazards that increase fall risks for older adults. And who doesn't like something free? So this is a free tool that is provided by the University of Sydney. Then there is the Safer Home Assessment. So it's safety assessment of function and environment for rehabilitation, health outcome measure, and evaluation. So this evaluates the interaction between the person's abilities in their home environment and also their access across areas of the home. And it includes recommendations for modifications. Another tool is the IHOPE, or the In-Home Occupational Performance Evaluation. So this focuses on the environmental barriers affected by that affect the performance of daily activities in the home. It also guides the therapist in prioritizing home modifications to improve function and safety. And unfortunately, this one is for purchase, so you can find it for $80 at the University of School of Medicine in St. Louis, the Washington University School of St. Louis, sorry. And then there is the HSSAT, which is the Home Safety Self-Assessment. So one thing that the team and I talked about is just being able to incorporate buy-in with your patients. And so it's easier if there is an assessment out there that is a self-assessment tool that just helps them identify the hazards within their home. And it includes a checklist with solutions for common risks and instructions for home improvements. And this tool can be found for free at the Community Engagement for Disability and Aging Research website. Another tool is the FACTS, which is the ASHA's Functional Assessment of Communication Skills for Older Adults. It evaluates the functional communication skills in daily living, and it can also be found on the ASHA website. Some other cool tools that are not necessarily standardized but are very helpful are some technology-based tools. So there's mobile applications out there that provide layouts with the home. So you can take a picture of the home, and before actually making those changes, you can take a picture on some of the apps and do some rearranging on the app so that the client can see what exactly is going on and how this may help, impact their safety in their home. There are also 3D home scanning tools. So these are advanced technologies like 3D scanners that create a digital map of the home for detailed analysis. Then we live in the age of social media, and so there are Facebook social media groups for home assessment. Some of the groups I've actually seen out there are both patient-led groups and therapist-led groups. So the patient-led groups are basically like community members, neighbors who are all in a group together, and they just share recommendations. Like they can share something that worked for them as far as a change in their home. They also share like contractors or just whatever their neighbors or community members may need in order to help make their home safe. Some of them even take pictures of their home and ask for suggestions from each other. And then the therapists led groups are usually pretty much the same thing. So therapists are out there just asking other therapists for recommendations for maybe a client they have or an idea they have. So social media is a helpful tool for home assessments. There are also activated voice assistants such as Alexa and Siri that can answer questions, set reminders, and provide information through voice commands. There are reminder devices that can be set to play messages at certain times or detect motion within the home. For example, you can set a device to play a message when you walk out of the kitchen to remind you to turn the gas off on your stove. And there are, of course, our smartphones and tablets. So these devices may help with some of those apps that we talked about earlier, and they can help with memory, including apps that are specifically developed for people with dementia. There are wearable timers. So these allow for people to set timers for day-to-day activities, like how to run a bath or how long for medical appointments, that kind of thing. And then there are also GPS route finders. So these devices can help you find your way to new destinations and can often be programmed for specific requests. So the role of the therapist in home assessments, what most therapists do. So the first thing is identifying environmental hazards through observation and evaluation. So therapists assess potential hazards such as poor lighting, slippery surfaces, loose rugs, or clutter that can cause a fall or an accident. Then we check for environmental fit. So they evaluate how well the home environment supports the individual's physical, cognitive, and sensory abilities. We also evaluate functional needs through an activity analysis. So therapists analyze how individuals perform daily activities in their home in order to identify whatever challenges that may come to their clients. We also do mobility and accessibility. So we assess how well the individual navigates the home, including doorways, stairs, and furniture arrangements. And we just note any barriers to assistive devices like their wheelchairs or walkers. We also collaborate on intervention. So like I talked about earlier with buy-in, we are not the ones just giving out information. Of course, you want your client to buy into your suggestions for their safety. So we collaborate by making recommendations and just guiding with the modifications, such as installing grab bars, stair rails, ramps, non-slip floors, or widening doorways. We also do look at assistive devices. So we suggest equipment like shower chairs, raised toilet seats, or bed rails to improve safety and ease of use. Then there's also education, which is very important, of course. If you're helping with any of these assessments, you also need to educate your client on how to properly use things like their assistive devices. Then we provide recommendations, so we customize solutions. Therapists tailor interventions based on the client's specific needs, preferences, and financial resources. We give feedback or give reports to the clients, so we provide detailed reports to families, contractors, or funding agencies, specifying the necessary modifications and why they're important, and then also monitoring and follow-up. So of course, you can't just do an assessment or make a modification and then just leave. You have to see if it works. So therapists also can return to evaluate whether the modification meets the person's needs and if there needs to be any changes necessary.
So now we're going to break it down into individual disciplines as to what our role is in that home assessment process. So starting with occupational therapy, the occupational therapists teach safety during participation in activities of daily living, as well as in those instrumental activities of daily living and any other activity that is important to those patients and clients. Occupational therapists are trained to identify safety issues and solutions, which allow us to assess a home and make it safer to reduce the risk of falls and maintain successful independence. Occupational therapists also assess medication management, also including problem-solving ability, strength, balance, nutrition, routines, home safety, and a number of other things, all of which can contribute to a person's ability to live safely within their home. For physical therapists, their role in the home assessment process includes the environmental assessments that we've been talking about, also the patient assessment, looking at their medical and treatment diagnoses and how that will impact them within their home environment. Looking at standardized balance assessments, the use of adaptive equipment and prosthetics, gait and balance assessment, looking at analyzing and also training that patient based on those deficits, stair negotiation training, looking at training a patient with fall recovery, fall prevention home exercise programs, always including caregiver education in the process as well, and also looking at energy conservation and work simplification techniques to make that patient as safe and independent as possible. And then looking at our speech language pathologist role within our home assessments. Observing daily routines. How do challenges impact the patient's ability to perform everyday tasks like eating, drinking, talking on the phone, or following instructions within their home environment? Looking at functional communication evaluations. How does the deficit affect the patient's ability to communicate effectively in real-life situations, including understanding conversations, expressing needs, and using appropriate language in different social contexts. Including a swallowing assessment. Observe the patient's swallowing during meal times, looking for signs of dysphagia, like coughing, choking, or food residue in the mouth. Cognitive assessments, including evaluating their abilities that may impact communication, such as attention, memory, and reasoning as needed. Looking at their environmental analysis, identifying those potential environmental barriers that could hinder communication or swallowing, such as lighting, noise levels, seating arrangements, or cluttered spaces. And then once again, we're going to include caregiver education, teaching those caregiver strategies to support the patient's communication and swallowing abilities, including communication techniques, mealtime adaptations, and positioning strategies.
So when we look at this in summary, research has shown that about a third of community dwelling elderly population are at risk for falls each year. Most of those safety hazards to the community dwelling elderly population are preventable. So by conducting a thorough home safety assessment, we can prevent these falls. There are tools that are readily available that could be utilized by patients and healthcare providers to help identify and manage hazards in the home. Rehab professionals like your OT, PT, and speech have a major role that they play in conducting those home safety assessments and for making recommendations that will make the elderly population live safely in their homes. So in conclusion, home assessments are a key part to discharge planning for any patient that's preparing to return home. Modifications, adaptations, and adaptive equipment and assistive devices are many of the resources and tools that can be implemented to increase a patient's ability to remain at home with increased confidence and safety with those daily routines. All therapy disciplines play an important role to providing the education, facilitating the safety, and enhancing independence for patients to safely remain within their home environments as long as possible. So just remember, get those assessments done and move more.
So we are nearly the end of our presentation. Just a reminder that, this is Aegis Therapies. If you're interested in joining Aegis, these are some, the barcode that you can scan. You have the phone number here for employment manager. We are all over the country. So, this is one of the things that we do as a company. And we're always, open that people can have people join our team. Now, Catherine, do we have any question?
There aren't any questions in the chat just yet, but if there are any questions, if you'll just put them in the chat, we can try to address those.
There are a couple in the question box, and I will just read the first one to you. It was, any good tips for managing long oxygen cords?
I can answer this one. For long oxygen cords, not necessarily the cords, but I have worked with patients who are on oxygen and they just get the portable ones that are easy to carry, so that way they don't have to deal with the cords, if that helps.
And I also feel like sometimes the cords are too long for what they actually need. And that's when they become a problem, because that's when they get tangled. They have this extremely long cord, but they really don't need that long of a cord.
And so the next question in the question box was, I believe, Crystal, when you were speaking about the mobile apps, is there a list of the names for the mobile apps for layout options?
I actually I did not collect a running list. I was just looking at some and talking with the team, but I can find some, and I do have a list of some of those Facebook groups that I was talking about, and they also have apps on there.
Okay, so perhaps if you could get those to Shyla, and then for those of you who would like to get that list, reach out to Shyla Hamrick. Her email is in the chat box, and she can forward that on.
Okay.
Another question is, how do you advocate for home assessments when the facility may not support them?
So one of the things that we do at my facility is that we encourage the actual patient to go home with them for the home assessment. So that way it can be covered under a treatment for that patient. So I usually either send my therapist that's going to do the evaluation, have the family member come get the resident, take them to the house, and actually walk them through those areas so that we can address those things. But it can also be, counted as part of their treatment, so it's not just downtime.
The other thing that we did during the COVID era is that actually having a family member at home with a device that maybe they can be on Team or FaceTime, or that we can actually, or we can see what is going, how the home is set up, where things are placed at the home, like the size of the door, where is the bathroom, do we have a shower chair, and all those kind of things that might be needed to make our home safe for the patient. So, if for whatever reason, maybe the home is too far, or the family member, they're not able to get transportation to take the patient home for a home assessment, we can do a virtual home assessment as well for the patient.
Right. And then another question, actually it's two questions. On average, how long does a home assessment usually take? And also, how soon prior to discharge is a home assessment recommended?
That is a very good question. Generally, being in the home usually take between 45 minutes to an hour to do the thorough assessment of the home. Remember, we're going to start from the outside, walking into the inside, assessing various aspects of the home. And, maybe if the patient is at home, we need to see how they function, their routines and habits, things that they do, around their home that will be able to identify if there's any kind of fall risk or things that might, limit their mobility in the home environment. What's the second question again?
It was on average, how long does a home assessment usually take? And also, how soon prior to discharge is a home assessment recommended?
Oh, thank you. Yeah, I always say, we don't want to wait till the last day or the last week before we start thinking about home assessment. As we start working with the patient and we see how they are performing, we want to make sure that, I would say, in about 2 weeks prior to discharge, I would recommend that we take the patient home and see how they're able to function. That gives us room, an opportunity to be able to address any kind of limitation that we see or things that we need to work on before they go home. So, it's okay, totally okay to take them home, 2 weeks or maybe a week and a half before they go home to see how they function around their home setting. That makes it, effective for us to be able to provide any kind of treatment, any kind of support system that they might need when they go home. We can make those recommendations, and that will help the patient to be able to function well when they get home. Good question, though. Good question.
The next one is, are any tips or ideas you have on convincing patients to modify furniture when they're so used to their setup?
Who wants to take that?
Can you repeat the question?
It's a good
Any
question.
tips on convincing patients to modify their furniture setup when they're so used to it?
I actually had to do this today. There are a few ways, one of which unfortunately can be a scare tactic. I know it sucks, but just showing them what, that piece of furniture can possibly cause if it stays where it is. So, for instance, like today, my person that I had to convince to move around some furniture, she started crying at the thought. And so I just had to let her know, you just had a fall. And this piece of furniture is, a fall is preventable. And this piece of furniture is the cause of said fall. So you have to pick which one. It's either at this point, it's the furniture or you in a hospital or worse, and it's very unfortunate to have those conversations, but they need to be had. So that's one way.
I also
Yeah.
think, I was just going to say, I also think if you give them the statistics sometimes, that's the reality of it, right? Like how many falls are happening, how many deaths are happening in their age group. Do you really want to stay home longer? Just kind of putting the ball back in their court, sort of to say, if you're wanting to stay home longer, we need to provide that safest situation or that safest setting.
Yeah, one that kind of comes to my mind is some of the mobile apps or 3D picture that we can take at home, that we can move those furniture to different part of the room, and they can see how much space it creates for them. Just kind of showing them if the patient is, maybe in their institution, we're still working with them, and we have the family take a picture of the room or maybe the living area, and then we can actually digitally kind of move the furniture around and say, this is how much space you're going to have if you move furniture to this side of the room, and this is how it's going to keep you safe, so that they kind of see, what the home how functional the home can be. That might be something that we can use to kind of convince them as well that it's a good idea to move those furniture.
And we got some feedback in the question section, just someone confirming that they feel that fall prevention is a great approach for education. Just going through here, guys. Somebody else provided some feedback that getting social services involved in the home assessment process also may help with justifying a reason for an assessment. So just some food for thought.
Yeah, that's a very good point, because the social service, they can help navigate through the family issues, they can navigate through the insurance issue, or any kind of barrier about obtaining any kind of equipment or modification might be needed for the home that the insurance might be struggling with. That's a very good point. I kind of agree with that.
Is there a specific home assessment that insurances like to see? Anything y'all are aware of?
From my experience, no.
No, either. I think the biggest thing is, just documenting the home evaluation itself and the different areas that were addressed and assessed and the recommendations that were given to patient and family. Just like we would a daily note on anything else.
Do you all know what CPT code is used for SLPs for fall assessments at home? Anyone have one?
I'm honestly not sure. I often let my PT and OT actually do the assessment, and then I just send my recommendations, like if they give me feedback from what they find at the home, I then provide those recommendations for safety. I don't often do the actual home assessment myself.
Best approach for patients who are residents to home changes due to their comfort level. Sorry, I'm just reading the way it's typed, so.
Yeah, I didn't really get a question.
Oh, maybe it's resistant to home changes due to comfort level. Yeah, so best approach for patients who are resistant to home changes due to their comfort levels. It sounds like you guys maybe covered that with the furniture layout.
Yeah.
Yeah,
I mean, maybe they have their favorite chair, the way they position the TV and things like that, that just getting somebody to make certain arrangement or to kind of move some of those things around might help to maintain the same level of comfort or with a new, safer environment.
Someone said that we mentioned apps to help people remember things such as turning off a stove, remembering doctor's appointment, etc. What about someone who isn't used to using devices? Many of the elderly population who can't remember how to use a device. Any suggestions for improving that recall?
I have had experience with one situation like this, and what we ended up doing was this patient had a very involved children, like older children, specifically her daughter, and her daughter just installed a camera of cameras throughout the house, but I think not in the bedroom or the bathroom. I can't remember. And so the daughter would just, because she worked from home, she would just monitor her mom and then just speak on the camera to remind her that she needs to turn, something off. But that was the only time I've had to experience where, the client just is not into, apps and technology. And so that's the suggestion that we ended up the path we took.
Yeah, I was going to say, I know that one of the options would be to include their children. Maybe the child even sets up the app, right? So that they don't actually have to use the device. It just, you know, is set for certain times, like if it's a timing thing for medication or something like that.
Able to kind of monitor how it's
Mhm.
going at home.
Yeah.
Right. Got someone wondering if you have any suggestions for when the home has structural safety issues. I once had a patient insistent on returning home. There are holes in the porch and questionable safety with the electrical lights flickering on and off, possibly due to shorts in wiring. Anything besides alerting adult protective services. This person could not afford repairs. Any resources you all are aware of?
I know I'm from South Carolina, and so a lot of times our churches are willing to provide some services for needs at home. I like they've provided ramps and things like that before, even provided fixing porches that had holes in them. Maybe not so much with the electrical work, but oftentimes there's someone in the church that is an electrician that's willing to, kind of donate some time for those individuals that can't afford that. But you really just kind of have to ask around to what options there are in your area.
I think that's where social services kind of comes into and helping kind of find those resources. I know around where we live, we have a lot of different services that also that I've dealt with patients in the past who have turned to like veterans care services, and they will offer ramps and different things, just like you were saying the churches would, for different veteran services.
Yeah, and there are programs out there with budgets. I lived in Baltimore for a while, and there was a program at Johns Hopkins that had a budget for um, a contractor to go into a home and fix anything in the home that was a safety hazard up to a certain amount.
A few people just put in their suggestions too, saying that local Boy Scout groups sometimes offer help with ramps and porches, that Alexa can often be set up to help with reminders. And for medication, I've had several patients who are using the Hero medication management system. It works well for early dementia patients. Smart plugs are great for family members. Local ADRC usually have resources. One said Habitat for Humanity may be contacted also. Another question, how do home safeties occur with PT and OT together, and how to bill for co-treat HSA?
Yes, when we've had both PT and OT go for a home eval, it's going to depend on who is taking the lead for certain aspect of the treatment. So, the PT is working on ambulation and safety around the home, that could be a PT intervention. And if the OT is in the bathroom, looking at the bathroom, the grabbery and stuff like that, that'll be another intervention. However, though, if there are areas that they are both looking together or they assisted the patient together, that could be billed as co-treatment. Now, the code that is billed depends on what is being done. So that's how I would generally bill for those kind of intervention that's done for patient when we're doing our home eval.
Yeah, I was going to say more specifically, let's say both PT and OT are looking at the bathroom. And so you can draw a clear line. Like PT is looking at the actual ambulation from, one room to the bathroom and their transfer to the commode. That's a clear line. OT is actually looking at their toileting, their lower body dressing during the toileting. So you can draw that line for the two, even if you're co-treating and looking kind of like at the same activity, but you're looking for two different things.
Just a few more suggestions that were sort of dropped into the questions, so clearing these out. Someone mentioned that they like to include a basic assessment of alcohol consumption into the assessment.
Yeah, that's a good one.
Speaking of back to the oxygen cords, someone mentioned placing a colored tape on the cord to assist with seeing it. And for long oxygen cord, a way to prevent it from being a trip hazard is to tape it onto the wall or ceiling. All right, guys. All right. Someone asked, elderly population is considered age 65 and older, right? And does a longer O2 cord decrease the actual O2 delivered to the patient?
Not necessarily, not from my experience. I've had clients with very, very, like Brandy said, cords that are longer than necessary, and they've been fine with it. They haven't had any complaints of feeling like it was less because it was longer or more.
Yeah, I mean, I think the pressure is evenly distributed unless it's twisted to form a clink that might that might obstruct the oxygen delivery. But overall, it should the length of the O2 cord should not decrease the delivery of the oxygen.
They've even been able to say like they can tell if someone's like stepping on the cord because then they can feel a difference. But outside of that, no one has ever complained of there being a difference in O2 getting to them from the cord length.
All right, great, thanks, guys. What do you do if someone has dementia and you already know they aren't safe to return home safely prior to the home assessment?
My
Can you repeat the question?
family members and kind of figure out what their plan is for home, or caregivers, and trying to see if somebody is going to be available for those things, and kind of if the patient is going to have somebody with them during the day and what that would look like for them, and kind of going from there as far as their needs. Now, if they're not going to have anybody, then of course our recommendation would be what amount of time or what the caregiver would look like in their situation.
Yes,
you.
I had it correctly. So, I mean, it has to do with what stage of dementia or cognitive decline the patient is at. It's one of the things that we do in EEG therapy with our dementia program. We're able to identify the level of dementia that the patient has. So with that, we can make appropriate recommendation as to the home needs, the caregiver requirements, maybe, 24 hours, maybe it's through certain times of the day that they can come and assist the patient. So those are the things that I would look into when I'm discharging a patient with cognitive deficit to a home environment.
I also wouldn't encourage doing a home assessment for a patient that their plan is to go home independently and we don't think they're cognitively ready. My assessment would be that they should stay and remain in the facility, because I think that's almost like, if we do the home assessment, we're assuming that we're going to send them home into an unsafe environment anyway.
Yeah.
I would just make sure they're going to have that assistance at home before I ever did the home assessment.
Very good point. Yeah, there's no point in raising their hope, thinking that they're gonna go home.
Right.
If we did maybe we did the ACL and somebody is functioning at a 4.0, we know they're not gonna be safe at home, and there's not gonna be anybody there. There's no point in doing that with them.
I know we're at the top of the hour, guys. It's just a couple more things here in the question section that I can get through. One person just commenting that resources for visual aids helps to prevent falls as well. And that regarding the O2 length concerns, they recommend using objective measures versus quote unquote no complaints. They aren't feeling well. Measure the O2 level so you're sure, but it was a great question. Regarding not remembering the use of an assisted device, how about using spaced retrieval techniques? And then lastly, and this sounds a little bit like the question you guys had before, but maybe a little bit different. Someone's just asking, what if the patient has a head injury or on other precautions, like an anger precaution, where the patient wouldn't attend the home eval with the therapist? Is that unheard of?
I've had home assessments where the patient was unable to attend, but I mean, it's just not considered therapeutic as part of their therapy, so you would have to, it would be downtime, right? I mean, so you would have to just make sure that that was okay with the therapy company and with your facility, that you're going to have an hour of time basically unaccounted for per se, in the scheme of things. But if it's needed, most of the time, I've noticed that it was approved if it was something that was truly needed.
Great. And those are all of the questions. And I know we're just a little past our time, so we'll close it up. The handouts are still available in that section if people want to download those. And we put an email in the chat, and that's the person that you can reach out to for questions or more information. So thanks to everyone. Thanks to our presenters. If you guys have anything to say before we wrap it up, please do so.
Yeah, I just want to thank everybody for attending this course with us. Really appreciate it. This is one of the things that we do in Aegis. We have it every month, so be on the lookout for our next Impact Core series next month. Thank you very much. Have a good afternoon, everyone, or evening, wherever you are at.
Thanks, everyone.
Thank you.